Okay, so let's dive into acute tubular necrosis today, ATN for short.
Right.
We've gathered the key info on this. It's a really common reason for kidneys suddenly getting injured, AKI, acute kidney injury.
Yeah, very common. But the crucial thing, I think, is that it's often reversible.
Exactly. So our aim here is to unpack ATN for you, get the core stuff down quickly, based on what our sources say.
Sounds good. It's definitely high yield, something you see a lot, especially in hospital settings. Getting a good handle on it helps.
Absolutely. So let's start with the basics. What exactly is ATN?
Okay, so at its core, ATN is kidney injury, where the actual cells lining the kidney tubules, they die off.
The tubular epithelial cells?
Precisely. Think of the tubules as the kidney's fine-tuning machinery. They reabsorb vital stuff, secrete waste. If those cells die, that whole process just kind of breaks down.
And you said it's a top cause of AKI.
Definitely a leading cause. But like you mentioned, the potential reversibility is key. Those cells can sometimes regenerate, which isn't always the case in other kidney injuries.
Right. And what actually causes this cell death? Our notes point to two main pathways.
That's the main split. Yeah, you've got ischemic causes and nephrotoxic causes.
Ischemic. So that's about blood flow.
Exactly. Not enough blood, which means not enough oxygen or nutrients getting to those hardworking tubular cells.
So situations like really severe low blood pressure, maybe prolonged shock, or renal artery stenosis, things that starve the kidney of blood.
Spot on. The cells are essentially starved. Then the other side is nephrotoxic.
Toxic to the kidney.
Right, where substances directly poison or damage the tubular cells themselves.
Okay, so that would be things like certain antibiotics, maybe contrast dye used for scans, heavy metals, things that directly attack the cells.
Exactly that. Direct cellular damage from a toxin.
Makes sense. And who's particularly at risk here? Are there clear risk factors?
Yeah, the data highlights a few key groups. Advanced stage is one. Having pre-existing kidney disease already makes you more vulnerable. Severe infections, like sepsis, are a major trigger. Also, major surgery, episodes of significant hypotension, and of course, exposure to those nephrotoxic medications or substances we talked about.
Got it. So we know what it is, the causes, the risks. How does this damage actually stop the kidney from working properly, the pathophysiology?
Well, when those tubular cells are damaged or dead, their function just collapses. Normally, they're pulling back water, electrolytes, crucial things into the blood. They're also meant to secrete waste.
And that stops.
Pretty much. So you get fluid imbalances, electrolytes go haywire, and the kidney's overall filtering job gets messed up because the processing part isn't working. Ischemia is like a power cut. Nephrotoxicity is like, well, poison in the system.
Okay. Now, someone presents with AKI. ATN is common, but what else should be on the differential? What else could it be?
Super important point. You've got to consider other causes, like prerenal azotemia. That's poor blood flow causing dysfunction. But the cells aren't dead yet.
So potentially reversible faster?
Potentially, yeah. Then there's acute glomerulonephritis that affects the initial filters, the glomeruli. Or acute interstitial nephritis, often an allergic reaction in the tissue around the tubules. Different mechanisms.
And just how common is ATN? Any sense of the numbers?
Specific UK-wide data can be tricky to pin down granularly, but all sources agree it's a really frequent cause of AKI in hospitalized patients. Particularly in critical care, you see it a lot.
So what are the telltale signs? If you're assessing someone, what's the clinical picture?
Often the first big clue is a drop in urine output, oliguria, and signs of fluid retention, swelling, edema.
Okay.
Blood tests will show the kidney function declining, creatinine rising, and often electrolyte imbalances, potassium, phosphate, that sort of thing. Patients might feel fatigued, generally unwell, maybe confused.
And if it's really severe?
In severe cases, you get uremic symptoms because waste products build up, nausea, vomiting, sometimes even seizures if it's really bad.
Right. So how do we confirm it? Well, what investigations nail the diagnosis?
It's a combination. Blood tests are crucial UNEs, creatinine to track kidney function, maybe checking for specific toxins. Urine tests are vital too, checking the volume, looking for blood, protein, and specific gravity or osmolality can give clues.
Any imaging?
Yeah, usually an ultrasound or maybe a CT scan, mainly to rule out obstruction, check the kidney size and structure.
Some biopsy.
Sometimes. If the diagnosis is uncertain after the initial workup, a kidney biopsy gives you direct tissue evidence. But often you manage based on the clinical picture and other tests.
Okay, diagnosis sorted. What's the management strategy? What do we do?
It really boils down to three main goals. First, identify and manage the underlying cause. That's paramount. Stop the nephrotoxic drug, treat the sepsis, restore blood pressure, whatever it is.
Makes sense. Second.
Provide really good supportive care. This means careful fluid management, often needing restriction initially. Managing electrolytes meticulously. Correcting metabolic acidosis, which is common because the kidney can't excrete acid properly.
And third.
Preventing complications. Basically trying to stop things from getting worse while the kidney hopefully recovers.
And supportive care can include dialysis, right? If things are severe.
Absolutely. Renal replacement therapy, like dialysis, becomes necessary if the kidney failure is severe, meaning it can't manage fluid balance, clear waste, or control electrolytes on its own. It buys time for recovery.
What's the general outlook, the prognosis for someone with ATN?
It varies a lot. Depends heavily on the severity of the initial insult, the underlying cause, and the patient's baseline health, other conditions they have.
So mild cases might recover fully.
Yes, especially if the cause is identified and treated quickly. Kidney function can return to normal or near normal. But severe ATN, or cases where treatment is delayed, can unfortunately lead to permanent damage.
Meaning chronic kidney disease.
Exactly. It can progress to CKD, or in the worst cases, end-stage renal disease requiring long-term dialysis or a transplant.
Which highlights the importance of avoiding those complications you mentioned earlier. What are the main ones?
The big ones are fluid overload, putting strain on the heart and lungs, dangerous electrolyte levels, especially high potassium, that metabolic acidosis, increased risk of infection. And as we just said, the long-term risk of CKD or needing permanent renal replacement therapy.
So prompt, careful management is really the key to minimizing those.
Absolutely critical.
Okay, so wrapping up our deep dive on ATN, it's a major cause of AKI, often due to ischemia or toxins damaging those vital tubular cells. It's common, especially in unwell hospital patients, but critically, it can be reversible. Management focuses on the cause, supportive care, and preventing those nasty complications.
That sums it up well. Understanding the potential for recovery is really important.
It really is. And maybe a final thought for you, listening. How does knowing that ATN might be reversible change your urgency and approach when you first suspect it in a patient, compared to, say, an AKI cause known to cause more permanent damage right away?
Definitely something worth reflecting on.
For sure. Mull that over. And if you want to cement this knowledge or test yourself further, do check out pastthemsra.com and also freemsra.com for more resources.
Keep learning.